BIP and your DIP that you have to monitor. So if you think about it, 1, 2, 3, 4 joints that you're crossing with this. And you can screw the whole thing up. You should always start with something between the fingers. An ulnar gutter splint is what this is called. And that is for a splint that goes on the ulnar side of the arm. And it will treat anything from some ulna fractures to metacarpal fractures, your 4th or 5th metacarpal fracture, or any 4th and 5th phalangeal fracture. Got it? Now I started this one way up here at the fingertips.
I think I might have had this cast before because I broke my pinky on this hand.
Yep. Well, this is the splint. You wait. I'm not done.
Is not all fractures to the ulna get this?
No, not all. Some. What's the difference? You'll learn that as we go on. See how she's radial deviating? She's trying to help me. Can you see that? Yeah. You guys, can you see that little radial deviation? Yeah.
So how can you tell it's straight, zero? Like, goes like radial straight to the second finger, or?
No, that would be nice if I could sit there and tell you, oh yeah, it must be like this. Some texts will tell you that. I don't say that at all. You got to look at it and see for yourself. I'm not going to say, draw a line down your middle finger. No way. Because not all anatomy is the same.
You wrap this one with the slight pronation too.
Slight pronation. I think that's key. A lot of you won't think that. I mean, you'll be able to supinate and pronate in this. So a lot of people are like, why do you have to do it that way? Well, if you wrap them in supination, when they go to pronate, they'll be able to do it, but it twists their skin because you've wrapped them like this. And I'll demo that. Like whenever I do, well, you can't really tell on her yet. When I put the splint on, if I go to supinate her, you'll be able to see it. Back here, her skin will twist. And over time, that'll eventually go away as the padding loosens up. But most of the time, people, they put their hands are pronated so they can grab stuff, do stuff right. Mm-hmm. Their hands aren't like this. Yep. Mm-hmm. They're never like that. Rarely.
Why did you choose to treat this with a splint versus a cast?
That's a very good question. That's a very good question. So, splint versus cast has a lot to do with swelling and acute injuries. Does that make sense? So, somebody that just broke their hand, they're going to swell up quite a bit, right? Or their foot. Whatever it is they broke. Immediately, as soon as that breaks, the bone bleeds. A lot of blood that comes out. All the soft tissue tears around the bone. That's when you go ow, and you swell up. So, because of that swelling, you have 48 hours, typically 48 hours, sometimes longer, that you will continue to bleed before the body shuts off the bleeding. So you will continue to swell, get bigger and bigger and bigger. You can't put somebody in a cast as long as they're still growing. If you do that, you cause problems. Do we do that? Absolutely we do it. Do we put people in a cast that just broke their arm? Sure we do. We try to reserve that if we're going to set the bone back in place. We tend to put people in casts then as well. Can we put them in a splint and set the bone back in place? We can do that as well. We have options that we can do. But a lot of places tend to put splints on for the first 48 hours up to the first week and then put you in a cast. That's the standard of care, so that's what you'll end up doing.
You'll put a bone back in place before you put a cast on, though, right?
Sometimes I do it while I'm putting the cast on.
Yeah.
So it really kind of depends. And then there's different variations. I consider different variations of reductions. So the more severe ones, they get the ones where I don't put the cast on, I put it back in manually, then I put the cast. The more easy ones that can fool you, the ones that you put the cast on and then try to do it.
Are the clients on medication?
Sometimes, sometimes not.
Depending on the severity.
That and depending on how long it's been since they broke their arm. So knowing what I already taught you, the first 48 hours they're bleeding inside there. Short of putting someone to sleep, you're not going to stop all their pain. We can sedate them to just about where they're ready to fall asleep. The second I pull on their hand or their arm or their leg, they're going to wake right up. Ah! So what you can do, if it's been within 48 hours, is you can numb up the same stuff that the dentist gives you for your gums. You can numb up the blood around that bone. And sometimes that does a very good job. We call that a hematoma block. Sometimes that does a very good job of numbing up the area so that we can put it back in place. You can do a nerve block. That will definitely shut down your sensation to where you can't feel it. But that's highly unlikely. We at Kaiser, we tend to go straight for the hematoma block. At Children's, they'll sedate a child sometimes. Knock them just, you'll see this, knock them out just about to where they're out. And then, boom, they crank on it. Patient screams wide awake. They don't remember you. It's kind of nice. But, but they still wake up and they still have pain. So, I don't know what's the best way or not. If it was me and I was 10 years old, I don't want anybody putting hey, another pair of gloves?
A shot.
Yeah. At 10 years old, I didn't want a shot in my arm. I would rather just gutted it out. So, I always ask the patients. Plus, it takes longer. If I have to wait for a doctor to come put a block in, it takes forever.
You also use the splint after they're out of their cast sometimes?
Yes, the removable ones. Absolutely.
You guys waiting? Yeah, I was gonna wait for Michelle so we could go at the same time.
Oh, Michelle's coming too. Oh, it's like a little reunion.
Just kind of late, but go figure. It happens when we
It
work.
happens when you get a real job, huh? So this is a 5x30 splint. It's a little wider than what I used before. I used a 4x15 on her. I went a little bit wider. I'm catching the fingers. I actually fold it over. I'm not a big fan of folding, but in this specific splint and on the radial gutter, I will fold around the fingers. This is how I did. I just actually made it a little bit thicker. Makes it stronger. This is the one that you're going to break, people.
So this one you don't cut out anything, just cut
I
out
didn't
the
have
top.
to. I didn't. Yeah, just the length of it.
You with that crease, you fold it up and out.
I just folded it. You can kind of see how I did that on her. Not everybody's going to get that. If they have bigger fingers, you're not going to have that problem. Does that make sense?
Fold on both sides?
I did. I folded on both sides.
Fold it.
I got an ace wrap. I'm on a time frame, people. This thing's got 3 to 4 minutes, right?
So you don't want us to put the
Web roll.
web roll on before you put the
No, you can. I want you to. I just didn't want to.
Okay.
Now, you got the slight pronation. You got the 15, 20 degrees of dorsiflexion. Here's the hard part, people. Without getting any creases, you have to get her MCTs down to 90 degrees, her DIPs and her PIPs, which is, what the hell is that? Those have to be 0. Okay? And you cannot get radial deviation. You cannot get ulnar deviation. Got it? This is the one that breaks on you. Where does it break? Right here. Why? Because you don't know when to stop messing with it. I'm done. I have to stop messing with it now. I probably have a few minutes to keep, making sure that I don't have any wrinkles, and I don't. Sit and wait.
Why do you
90 degrees at the MCP joint. I'm going to show you on my monkey.
What does that mean, metacarpal?
MCPs is the metacarpal phalangeal joint. The PIPs is the proximal phalangeal joint. The DIP is the distal interphalangeal joint.
Looks like it's okay to use your fingers.
No. I mean, I have it on there because I'm trying to protect her from moving
Okay.
more than anything else. I do put my finger right in here and bend over my finger, if that makes sense. Because I'm trying to prevent a big giant crease right there. Now, you are going to get creases in there. That's just going to happen. You can't take a piece of plaster and bend it over a 90-degree angle and not get a crease. Okay, but you want to limit that.
Did you go all the way to the base on the fourth metacarpal?
I went all the way to the tip. Yeah.
Is that going to rub on the third?
No. I'll show you what I went around so that wouldn't happen.
So the tips of my fingers, my pinky and my ring finger are out.
They are. I can see the tip, and that's all I want to do. I don't want your finger sticking out of this thing.
Yeah.
You guys will bring up a perfect splint, and the part of the finger will be sticking out, and I dock you for it. Don't do that. To me, the removable ones are a lot easier to put on, or non-removable, are a lot easier to put on than the removable ones.
And again, the rub roll is 5 to 6 layers.
Yes.
Yeah. And if you do double, it's 2.
Mm-hmm. Any questions so far?
When somebody has just a phalangeal fracture, is that necessary to stabilize wrist and ulnar?
It depends on where it is on the phalangeal. It really does.
Only phalangeal fracture?
If it's a PIP fracture, sometimes it's indicated. If it's a DIP fracture, most of the time it's not.
Oh, okay.
But this covers all the bases. So this is what you get in the emergency room most of the time.
In the hospital, like patient leaves with ACE wrap or take the ACE wrap off and then go.
What do you mean?
Like after visit, not to cure time, set time,
Uh-huh.
and then it takes 24 to 48 hours to
For plaster to dry.
the plaster to
No,
dry.
that stays on. The ACE wrap stays on.
Oh, okay.
Does not come on.
Oh, okay.
Any questions so far? See, this is your metacarpal. Right here, it tilts back. That's your MCP joint. So you got to maintain a 90 degree, 75 to 90 degrees is actually the mark that they want you to be at. The reason for that is so that you don't get stiff. You have a ligament, longitudinal ligaments that run from one side of the phalangeal to the metacarpal, and when they're flexed down like this, they're taut. If their fingers are out straight, they're lax. So whenever you cast them like this for a couple of weeks, you take them out of a cast, they can't bend their fingers down. Got it? If you cast them like this, take them out of the cast, they have no problem moving up or down. They might be a little bit stiff, but nothing like as if you were to cast them straight. Got it? Mm-hmm. Now, the way that you guys are going to make it, remember I showed you this way? But I'm going to show you real quick with the other hand. Mm-hmm. This is a 5x30 splint. So this is a little bit long. I'm going to waste a lot of it so I can show it to you.